Hey, what's up, everybody? I'm Dr. Feigenbaum. I'm joined with Dr. Baraki. As always, today we're talking about testosterone. All right, thanks for joining us here on the Barbell Medicine YouTube channel or podcast if you're listening. Austin, what's going on, man?
Doing all right. This lovely, nice, warm, let me see, it's about almost 70 degrees here in San Antonio on Christmas Eve. Can't complain.
So what you're saying is global warming is real?
Yeah, for sure. I'll not complaining. It's fine.
It was in the 30s the other day here in Santa Cruz, and I reconsidered life. Not gonna deal with it. So we'll cut right to it because we had a lot to talk about today, and I want to get into it. We're going to talk about testosterone today, or if you live below the Mason-Dixon line, testosterone. So first off, let's tell people what testosterone is. So I'll let you kind of lead the charge here. What is testosterone? Let's start with where it comes from.
Yeah, so I think most people's understanding of testosterone is basically limited to the idea that it is like the prototypical male hormone. It's what makes quote unquote men, basically, from a physiological standpoint.
A lot of people just got triggered. So let's.
We've talked about some of there is admittedly like this biological kind of gradient that we've talked about in the past, including some like genetic conditions, androgen insensitivity, things like that make this whole topic a bit more complex. Do you want to talk a little bit about that?
Yeah, we're going to get into it for sure. But I think what I want to just clarify is that when we say prototypically male, and I don't want to be too pedantic about all this stuff, but we're talking about things, characteristics such as broad shoulders, lots of lean body mass, being able to respond very robustly to training, for instance, particularly in the context of either resistance training or sports performance. When we talk about like prototypical male traits, also, if we're talking about just in general, excess body hair, deepening of the voice, things of that, these sort of secondary sex characteristics that are typically attributed to males. And I don't want to go too far down this rabbit hole and be overly politically correct about this sort of thing, because I think when you're discussing issues like this, it's difficult to walk that tightrope.
I think the main purpose of what we're talking about today is to kind of address this from a biological, physiological standpoint and how it pertains to people's training. Consequently, there are some interesting kind of psychological issues at play here that we run into a lot with some of our trainees. So I think we're going to get into that a little bit as well. But you definitely listed out, the typical secondary sex characteristics that we talk about. Those are the things that will commonly become more apparent in a pubertal, post-pubertal male when that hormone tends to rise very significantly. So basically, testosterone is it's a steroid hormone, and steroid just refers to a certain component of the chemical structure from an organic chemistry standpoint. And it's synthesized from cholesterol, interestingly. We talk about this in some detail at our seminar about, people talk about good cholesterol, bad cholesterol, things like that. And really there's just one thing called cholesterol that has a whole bunch of bodily functions. And one of these functions is to end up being utilized in the synthetic process to produce testosterone. And it's produced in both men and women, but there's usually at least a 20-fold difference in daily production of testosterone between men and women. The predominant proportion of it is synthesized in the male testes, but also there's a small proportion of it that's synthesized in the adrenal glands, and that's primarily where it'll come from in women as well. So that's kind of the basics of what it is, what it does, and where it comes from.
Right. So, and then it effectively, one of the more interesting things about testosterone, as far as its sort of function from the get-go, all fetuses are the default programming is to become female, right? So no matter if your genotype is XX or XY or something in between, the default programming is to become a female unless told otherwise by the presence of testosterone. So if you have an XY genotype and you're functioning normally, you have this SRY region of the Y chromosome that effectively ends up allowing testosterone production to occur within the fetus, to get the Leydig cells of the testes to also pump out a little bit of testosterone, which ultimately changes that default programming from female to male. And then as we would expect with humans being more complex, some things can go wrong, many things can go wrong, or many things can go a little bit differently. But in any event, that's kind of how we start. And so later on, we're going to discuss kind of the effects of testosterone and its various levels on performance. But what we're going to see is that it's not very cut and dry. There's a lot of gray zones, and you needing to know that from the get-go, testosterone has an effect on human tissue morphology, human tissue characteristics. For instance, like the nervous system is heavily influenced by testosterone from the get-go, from being, literally in the womb. So testosterone's got a ton of different functions, and I think you summarized it nicely as far as what is it, and kind of what it can do. As far as its as far as its use in the clinic, I think I think our experience has more to do with people wanting to figure out if they're low on testosterone. So I think this is a good time to just kind of go over how do you test to see if you have low testosterone.
Yeah, so this is something that if for people who might prefer to learn it, I guess, more in writing versus auditory visual, I wrote an article about this on the Starting Strength website you can check out. But basically, the diagnosis, what we're looking for when we talk about this low T, that's what you hear on the commercials, that's what you see on some of the billboards when you're driving down the highway. The term, that's like the lay term for the clinical diagnosis known as hypogonadism, meaning your gonads are functioning suboptimally. And so basically, when I say it's a clinical diagnosis, not meaning that you can just completely diagnose it based on someone's history and their symptoms they complain to you, but the decision to test someone's testosterone levels is typically going to be driven by a certain complaint, meaning they're going to come in complaining of symptoms that might be suggestive of the diagnosis that you will then pursue and evaluate for. And this is how we do things in most of, in the majority of medical situations, except for in those situations where screening ahead of time has been deemed, based on the research on the matter, to be valuable for a number of reasons that we've talked about in other settings in terms of what makes screening valuable. So it's typically tested for in the setting of suggestive signs.
So yeah, this is a laundry list of sort of, what you and I have described as some non-specific symptoms, and then also reasonably specific symptoms.
I think it's basically a spectrum of less specific and more specific symptoms, and basically the further down this spectrum you go, the higher your likelihood, or your we would call it your pre-test probability of something like this. Sure. We don't want to get down the jargon land too bad, but the most non-specific of them, for example, would be something like fatigue. We have a lot of people who train with barbells or who are coached by some of our barbell coaches, and they complain of fatigue, and so that kind of tips off a thought, hey, maybe you have low testosterone, and it's possible. Other things like decreased lean body mass, increased body fat, obviously that's super common, which means that it's not particularly specific for this condition, but it's something that can be consistent with having low testosterone or hypogonadism. Certain types of mood disturbance, sleep disturbance, loss of libido, that's the first thing a lot of men think about nowadays. Is having to do with testosterone. Things like actually reduced bone mineral density and osteoporosis in men actually is something that, if I see a male with osteoporosis, I'm actually immediately going to test that testosterone levels. See that in certain situations as well. And then infertility, loss of body hair, and rarely erectile dysfunction. I only say rarely because erectile dysfunction is not the typical manifestation of this in the absence of any of these other symptoms. So if you have such low testosterone to the point where you have erectile dysfunction as a result, it's typically going to be accompanied by a number of these other conditions. If your energy and your libido and all this other kind of stuff is fine and there's just erectile dysfunction present, it's pretty unlikely to be related to primarily testosterone-related causes. It's more likely due to things like diabetes and neurologic, vascular, or psychological causes as well.
Yeah, that was actually, there was a bulletin released by the American Lipid Association, again, this is back in 2012, was suggestive that, when dealing with erectile dysfunction, one of the first screens should actually be for coronary artery disease or peripheral vascular disease, just as that's a very common presenting symptom. And again, in the clinic, people are, the physicians or healthcare providers going to be sussing out like, okay, what is the cause of this ED, or what are the potential contributors. So is this like a mood disorder, for instance? Is this some anxiety? Is this or more vascular or other cause? But yeah, I think we get a lot of people who are like, hey, I should just check my testosterone, right, just to see what it is. And it's like, well, not necessarily, because if you don't have any symptoms, I'm not sure if I'd want to do anything about it anyway.
Yeah, it not only that. So I had a patient actually who requested something like this recently with me, and I said, look, I'm here more as a consultant for you. That's kind of my role, to make certain types of recommendations, and I want to make sure that you understand the implications of what you're doing if we do decide to undergo this screening process, and just check your number, quote, just to see where you're at, because we have a lot of guys who want to do this, particularly people, again, who train, they're in the strength training world, they're into, having a lot of muscle mass, being real strong, and they associate all that with testosterone, and they want to make sure that they're kind of as optimized as possible. That's kind of an understandable position to be in. They want to make sure that they're not like missing out on anything by not knowing, or if there's something they can do about it. But again, in the absence of any symptoms whatsoever, it really suggests that the endocrinologic system, that particular system, is actually functioning fine. Additionally, if you were to check and you get a certain number, it leaves us very unsure of what to do with that information. And the reason why is because the normal range, as we'll discuss when we talk about testing, is fairly wide for total testosterone in men. And so it's so wide that reflects probably a lot of complex underlying physiology that we might not even completely understand. One example of this concept is, there might even be some degree of variation in sensitivity of their testosterone or their androgen receptors throughout their body that leaves them feeling normal at a given level, whereas someone else might feel symptoms at that level. This is something that we have not completely figured out yet in the research literature, but it's something that, again, can be kind of a confounding factor. And so if you're in a situation where you understand very little of this underlying physiology, you don't really know much about, but you just know that like high testosterone good, low testosterone bad, then just fixing those numbers but with medication, which can have some consequences, side effects, things like that, might leave you underwhelmed in terms of the results that you might get. You might be committing yourself to a lifetime of therapy that you didn't need. There's a lot of cost and all kinds of other stuff associated with that. So there's a lot of implications to consider when you want to just, quote, like, check to see where it's at, because it's really difficult to interpret those results in the absence of any symptoms.
Yeah, right. And actually, so I did some digging just in preparation for this discussion, because that was actually my initial thought, is that there's a heterogeneity, or put more simply, a difference in both androgen sensitivity and number of receptors, for instance, that the testosterone would actually bind to at a very different level. And in fact, there's some reasonable evidence, in my opinion, that actually what is occurring. And I don't think that's the only reason for the wide range. And in fact, if you read the American Academy of Clinical Endocrinologists sort of long-winded position stand on this, and they suggest that the range is due to a host of different factors. One, testing accuracy, that's a problem. Two, this sort of difference in androgen sensitivity. And so just to suss that out for the interwebs, that means somebody, if the range is 250 to 1200, for instance, which is going to be based on a lab, specific lab that you're getting tested at, the person who's got 1200, right? Everyone's like, oh man, I want that number, 1200, it's so high, it's awesome. Yeah, well, he may be less sensitive, and in fact is likely to be less sensitive to testosterone and its subsequent effects than the person who's walking around at 400, for instance, or 300. And effectively, that's one of the reasons why the range is so wide, because those two people have effectively the same biological profile.
If the signaling pathway is kind of proceeding uninhibited, then they're if at the end range. So basically, the way testosterone exerts its effects is it circulates throughout the body. It can get into the cell, bind something called the androgen receptor that ends up going into the nucleus of a cell and then initiating DNA transcription, translation, protein synthesis, etc. So basically it goes into the cell and stimulates protein synthesis of a variety of different proteins, not just muscle protein synthesis, bone, all kinds of other proteins get synthesized. And so if that signaling is occurring, sufficient with enough signaling is occurring to result in all the normal physiologic functions happening, then effectively we call you eugonadal, meaning you're not hypogonadal, meaning you have normal kind of gonadal function and testosterone signaling throughout your body. But definitely I agree that there's a wide number of factors that influence kind of this broad range we see. And I think one underappreciated component is how wildly testosterone levels can fluctuate on a kind of time scale. So I recently had a guy who came and he had just wanted a consult for this value, and he had 2 different readings that were taken, and they were like 150 points off. He was like, how can that happen? And so I had to kind of explain that's not unexpected based on the timing that you had it drawn and kind of the normal physiologic fluctuation that we expect to see in a lot of people.
Right. Yep. And especially day to day, even over the course of a day, which we'll actually talk about when we come back after this break about testing.
Hey everyone, thanks for listening to the Barbell Medicine Podcast. Hopefully you guys are enjoying it. I wanted to take a second and talk about GainsRx. GainsRx is now shipping Amazon Prime if you get it on their website, and through our website you can get a subscription where GainsRx is delivered to your door every month for a $5 discount per tub. The idea is that you take GainsRx pre and post workout. It's got all the right ingredients to maximize your performance, improve recovery, and ultimately give you the biggest bang for your buck when it comes to exercise supplementation. A lot of people ask me, hey, Jordan, why did you even make this supplement in the first place? Well, at the time, I was recommending people take all these different supplements. They'd have to get multiple bottles, dose the things properly, and people just weren't doing it. It was too hard to do. So I put it all in one supplement. You take 1 scoop before, 1 scoop after, and you're done. We typically see improvements in performance and recovery metrics when we track them. So the idea was, if you were going to supplement anyway and you wanted to take stuff that was actually going to work, let's put it all in one supplement. We'll put it out on the market and see how it does. So there's been a ton of people who have told me that they've gotten great results from it. Looks like things are going well. And so you can get GainsRx at the barbellmedicine.com store, or you can get it on Amazon. We really appreciate you guys, and thanks for listening. Make sure that you give us some feedback on our podcasts, and we'll catch you guys later.
Perfect. All right, we're back. The Barbell Medicine Podcast. Today we're talking about testosterone. I'm joined, as always, with Dr. Baraki. We're going to talk about laboratory testing. So we already discussed that it's probably not terribly useful to get a testosterone test if you're not having any symptoms. Okay, and the test is only like $80 to get a free testosterone or total testosterone number back. But if you don't have any symptoms, we're not really sure what to do with it. So let's say you have some symptoms that we described earlier. All right, Austin, tell us about how you would go about working somebody up for hypogonadism or low testosterone.
Yeah, so the initial, at this point, once somebody presents with symptoms that are suggestive enough to make me want to go down this kind of testing pathway, the initial kind of screening test of choice that I'm going to do is an 8 to 10 a.m. total testosterone level. And so the reason why we measure it at that particular time is because there is, in most folks, this diurnal variation where their total testosterone level in the serum will peak between those hours in the morning. And so basically, if your physiology, your body is able to produce a normal testosterone level at that time, then effectively we can say that everything is functioning as it should. And of course, throughout the day, subsequently in the day, it'll start to go down. There are a number of other things that can cause acute drops in that level. For example, food ingestion, glucose ingestion can cause that level acutely to drop. Sleep disturbance, so if you can cause that level to drop. Alcohol ingestion, acute exercise even can cause that level to drop acutely. So these are so for example, the patient that talked to me last week, he had a level that was measured at around 227, and he had like a huge breakfast just that morning. And then he went and had it drawn. He's been having some issues with poor sleep, and so he had it checked again when he was fasted at the right time, and it was like 475. It was like significantly higher, and he didn't have enough in terms of suggestive symptoms beyond just sleep disturbance for us to say that he probably had normal testosterone function. So the other side of this, in terms of, that's the first step to look at for someone who is concerned about their testosterone levels in the setting of some suggestive symptoms. But the other side of this is that remember, those symptoms that we listed were all very nonspecific, and that means that they can come from a lot of other things too. And in our experience, I think you would agree that a lot of times we find other causes to explain those symptoms besides testosterone. And the majority of people that come to us complaining of fatigue, for example, oftentimes we can trace it the majority of the time probably to their poor sleep habits, poor sleep hygiene, sleep apnea that's not been diagnosed, things like that. But there are tons of other things that, that we need to think about in somebody who, say, has fatigue, for example. Do they have, again, sleep disturbance issues? Do they have thyroid dysfunction issues? Do they have just primary mood disturbance issues? Like sometimes people have poor sleep because they're depressed, and it's depression that's not due to something like low testosterone, which is not something that's really recognized, for in terms of an isolated depression that's being caused by low testosterone, for example.
Caused by hypogonadism. Yeah, it's actually interesting. We could do a whole podcast on just numbers and statistics, even for this particular issue. But low testosterone is much more rare than a mood disorder, so depression, anxiety, something like that.
Way less common.
Right. Than poor sleep habits as an umbrella term to cover sleep apnea, parasomnia, or something like that. Hypothyroid, for instance, much more common than low testosterone. Anemia is much more common, even in men, which you wouldn't expect it to be. But the takeaway from this is that low testosterone at large is just less common than many other medical issues that we also have to either at least screen for when working this up. So I think our standard panels look pretty similar if we're going to send this out. So I would never send just an isolated testosterone, total testosterone or free testosterone, which just I'll say a word about. Right now, based on recommendations by the American Academy of Clinical Endocrinologists, you can send a total testosterone without sending a free testosterone. You can send both if you want. I haven't seen any recommendations that just say send a free testosterone. The total testosterone is kind of like the moneymaker. And I don't mean a moneymaker for like pharmaceutical industry or for the medical industry, but as far as it being like the most sensitive to kind of like to suss out, do you need to do further endocrinology workup? But at the same time, I'm also sending a TSH, I'm sending a CBC, I'm doing what's called like a stop bang questionnaire, which is a screening tool for obstructive sleep apnea. You can also do a Epworth sleep scale sort of thing for depression, or the PHQ-2, depending on what your setting is. So there's a handful of other things that we're all going to co-work up at the same time. And this is also assuming there's no additional medical history that may cause the symptomology that's being discussed here. So for instance, if a person has a history of like what we would previously call pre-diabetes or even frank diabetes, we'd work that up as well to see if it's worsening, for instance. So we might send another A1C. For instance,
HIV, I've seen that before. Sure. I mean, certain types of cancers, autoimmune diseases, tons and tons and tons of stuff can cause this.
Alcohol abuse, other toxic ingestions. So there's a laundry list of things that we also have to kind of co-work up once we decide to pull the trigger and go down this rabbit hole. It's not just let's check my total testosterone just for fun.
And if it's lower than I think it should be, then I'll just go ahead and get some injections, and I should feel magically better. It's definitely more complicated than that.
More nuanced, if you will. And you were waiting for that, but the thing is, some people would say, well, hey, look, doc, it's my money. Like, I just want to know the number, and what I want to reiterate to the people who are listening or watching is why, right? The number and the takeaway at the end of this whole thing should be you don't need to know that number unless you have symptoms, because it's not going to affect what you do in any positive manner. If the only thing it's going to do is hurt you, all right, based on what you've heard previously from trusted resources, we'll call that the Nocebo Effect, and your expectations of what you should be able to do or what you should feel like based on a number that is not clinically relevant at that time. So.
That's definitely a huge deal. So I think that out in the real world, when you see all these ads for low T clinics and stuff like that, and they're asking you, do you have this symptom, this symptom, this symptom, that are all super common, for example, they kind of set it up. They set up the expectations that they'll be able to treat you and just make you feel completely invincible when you go on their therapy, which from their standpoint is smart because it's going to get you in the door, and they're increasing your expectations to the point where they're bolstering both the therapeutic and whatever placebo effect they're going to get out of you as much as possible.
Right.
But we see it a lot in the lifting world where say we have somebody who's 18 or 19 or something like that, and say they like miss a rep on one of their squats, and that's like their trigger to go get their testosterone checked, and it's like 400. And somebody's like, well, you're 19, your testosterone should be 1200.
Poisonous.
Well, that's not true, and also it's going to significantly affect that person from a psychological standpoint, and subsequently affect their performance.
Sure.
Because they are then subsequently going to attribute any setback to that number that they now know about, that they didn't previously know about, that probably has no clinical significance. And also it can actually result in impaired performance. And so this is actually something that we're kind of building an entire kind of portion of our seminar lecture around, kind of the role of kind of the brain, expectations, positive and negative, and how that can influence your performance, even your recovery, even your adaptation, actually, which is another super interesting side of this, is like it can actually affect the adaptation that you get out of whatever stress a person is receiving.
Sure. So, all right. So let's say we have this patient come in. They say, hey, doc, I'm tired. I've been noticing decreased performance. I'm sore more often than not. I feel like I'm losing some muscle mass, yada, yada, yada. He has convinced you to go down this rabbit hole, all right? And so you get the first testosterone level back, total testosterone, and the additional lab and tests that you ordered. Everything comes back negative otherwise, but the total testosterone is 220. And again, we assume that the normal range is about 250 to 1250 or 250 to 1200, depending on the lab. And let's say they're below that 250 cutoff, okay? So what is your next step in management?
Yeah, so the next step is actually, and this I've seen, some people get frustrated by this, but the next time is a confirmatory test. So you check it a second time. And you check it a second time for a few reasons that I'll mention, but you also check it together with a few other related hormones, including FSH and LH levels. Some people will also check a sex hormone binding globulin at this stage as well. Those are a few other labs that can be drawn with this. But basically, I mentioned that there's this huge role of the diurnal variation in testosterone levels, and so you want to just kind of on a daily basis, like the day-nights kind of cycle that affects testosterone levels rising and decreasing, and you want to make sure that you're not missing a part of the day where the person is actually able to generate a completely normal testosterone level, which would suggest that everything is functioning normally. There's also all these kind of other confounding factors that I mentioned. If they have like sleep issues, if they ate beforehand, there's a number of other things that can result in a false positive initial screen that you then can exclude after you prove that they have normal testosterone. Their ability to produce a normal testosterone level is intact on a subsequent test. So I've had that happen a number of times where the subsequent test ends up being negative, and a lot of times for these patients by then we've talked about this enough that they see it as a relief because they're like, oh, I didn't want to have to go on this therapy for the rest of my life, and they see it as a good thing. Whereas somebody who's actually just fishing to try to get testosterone might be like, damn, I wanted it to be low so I could go on TRT and get huge.
Yeah, well, but that's an interesting thing though. So you and I both see patients in many different states, and sometimes we don't have the benefit of seeing them in person, which would potentially be a different situation. But and a lot of the time we're inheriting other clinicians' sort of work here. So if you have not had this correct workup, it is very difficult to have different providers prescribe you TRT. So let's say you've been on testosterone replacement therapy for whatever reason, but you have not had this workup, this correct workup, which again requires 2 different readings of your total testosterone, a negative laboratory workup for any other thing that may be causing this. I personally wouldn't feel comfortable prescribing testosterone replacement therapy or other hormonal therapy to somebody unless they've had this appropriate workup. And it's not that it's medically inappropriate, because I would hate to put to throw some shade at our colleagues here, but it's just, it puts us in a weird position, because then what you have to do is you have to stop TRT for a substantial period of time unless you think that the clinical benefit is outweighed by what may happen in the interim. So what I mean by that is if I had a patient come in who's only had one total testosterone test without the additional lab workup, without a second confirmatory test, okay, and they need a refill on their testosterone, right? I'm between a rock and a hard place. So at that point, I have to determine, well, if they go off of TRT for 3 months, okay, do I feel like something terrible is going to happen? If I don't, then at that point I have to tell them, hey, look, you got to be off for 3 months, all right? And we know that during that time that their body's testosterone production should come back online to the extent that it can, right? And they may live with some actual symptoms of hypogonadism if they were indeed hypogonadal before. If they weren't, and then we test them 3 months later, then we're like, all right, well, you didn't really need to be on TRT in the first place, which may be a win, but that 3 months can be not a pleasant experience for some folks.
Yeah, and I think a lot of people don't necessarily understand the reasoning as to why that is, something that should be done. And I think a few examples might help to explain it. For example, let's say that you inherited a patient like that and you ended up just continuing their TRT because they were on it when they came to you, despite not having sufficient evaluation before. And then at some point down the line, they get admitted to the hospital like in septic shock because they had HIV this whole time that nobody diagnosed, and that was what resulted in them having low testosterone and having a large proportion of these symptoms. That's huge malpractice. Like you missed something very, very, very important. Alternatively, if you don't go through and you do the second step with repeating it, getting an FSH and an LH, things like that, those subsequent hormones that you also check help you to localize where the problem is. So there are different types of hypogonadism depending on whether the problem is primarily in the brain, the hypothalamus pituitary gland, or whether it's localized more towards the testes as the primary source of like testicular failure, for example, which is the less common thing that we would see, but the more kind of catastrophic that we wouldn't want to miss somebody who has primary testicular failure. And if that never gets evaluated and, like years down the line, they find themselves like, say they're completely infertile or they have some like infiltrating autoimmune disease or something that's affecting, say, one of those glands that you never evaluated. Those are also huge medical misses that should have been caught. So, it's easy for people who are not in the situation of making these decisions and prescribing these medicines to say, but here's my level, it was low, I clearly need to be on TRT, without kind of any understanding of the scope of what else could be going on that has not been ruled out that needs to be.
Right. To add to that, again, if the FH or if the LH or FSH levels were through the roof and testosterone levels were still low, you're thinking, wow, is there some sort of, there's a handful of cancers that can do that. Yes, things that you don't want to miss, not just so you don't get sued, but ultimately to provide the best care to the patient. So we're not just being jerks, like, sitting on a mountain of testosterone, just, it's just that we want to provide appropriate, thorough care for these folks. Other things, and again, I do think this kind of drives the point home that it's not all roses and prosperity on the other side of this TRT thing. If somebody has some polycythemia, that is, their hemoglobin is through the roof, the viscosity of the blood's very, very high, and you get that on your initial workup, and you haven't screened them for sleep apnea, for instance, and they have untreated sleep apnea. Well, putting them on TRT puts them at risk for an embolism or a clot, potentially stroke. Yeah, really bad secondary outcomes that people aren't. It's not necessarily on the radar because they're thinking, well, my testosterone was low, that's why I felt bad. It's like, well, no, actually, your hemoglobin was 18. Your blood has the viscosity of like motor oil. Yeah, motor oil, right? And that's why your face is purple all the time. So yeah, it's more nuanced than that.
I hope we've at least conveyed that take-home point to people, is that this is more complicated than, checking one number and treating that one number. There's a lot of other considerations that need to be made. And there's also, we need to make sure that that expectations and understanding and education is done appropriather. I think the point that you made earlier about the nocebo effect is one that actually deserves repeating, is that, again, when you tell somebody, no matter who you are, if you're in a position of authority, so this means if you're like a therapist, if you're a physician, if you're a coach, and you're telling somebody that, like you're doing some kind of amateur medicine and you're looking at this lab and you're like, oh man, I bet you must feel absolutely terrible with that testosterone level, for example. You say things like this, or it's no wonder that you missed your last rep, or it's no wonder that, you haven't put 200 pounds on your squat in the past 8 weeks. You're kind of reinforcing this negative kind of thought process that can have a number of downstream implications. And so you're actually doing harm by saying that stuff, particularly when you're not in a position where you can actually like assess and evaluate and just really think about these labs in the context of, the patient's symptoms and all the other things that need to be evaluated.
Yeah, my general rule of thumb, it's not like most trainers or coaches are taking the Hippocratic Oath or anything like that, but on the other hand, the ACSM, who is effectively the authority on pre-exercise screening, right? So the recommendation for them, for people who need some pre-exercise screening, are those with a known cardiometabolic history. So those who have history of heart attack, stroke, stuff like that, pulmonary embolism, people who have history of diabetes, hypoglycemia that's symptomatic, stuff like that. If somebody has no history, effectively the ACSM says, yeah, they don't really need any sort of physician clearance prior to initiating exercise unless you find signs, symptoms that are suggestive of a disease that would require physician clearance. And so with that, the practitioner, the coach is actually kind of charged with monitoring, like, hey, is this person like safe to train? Like, so there's some sort of commentary that may be there, but ascribing a positive or negative sort of connotation to certain medical things when you have the role of a coach, I think is inappropriate in general, unless you are equipped to manage or work them up. So anyway, we're going to take a quick break. When we come back, we're going to find out how we treat those with low testosterone.